Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about rheumatoid arthritis. When I left off last week, I spoke about methotrexate, how it works to treat and prevent the worsening of the rheumatoid arthritis, and I spoke about the biologics that are being advertised on television, the Humiras, etc., how they work. And I started to talk a little bit about, well, I did speak extensively about steroid, but I then began to talk about the aspirin and also non-steroidal anti-inflammatory medications such as Motrin, Aleve, Advil, and Mobic, and Naproxen, and the COX-2 such as Celebrex, etc. And of course, I will be telling you how these things are prescribed. But before I do so, I don't want to scare you, but I want to warn you to let you know some of the problems that can occur because of when one takes this medication. Not only they have the side effect that can irritate your stomach, etc., that can ultimately leave in ulceration of the stomach and so on. You have to understand there are many, many bleeding disorders in the world that one has to be very careful with when one is going to take aspirin and or NSAID. For instance, the number one bleeding disease in the world is von Willebrand disease. 110 million people across the world suffer from von Willebrand disease. 2.8 million people in this country suffer from von Willebrand disease. You say, well, what is von Willebrand disease? But von Willebrand disease is a qualitative platelet abnormality disease. Qualitative, meaning that because of von Willebrand disease, the platelets don't aggregate the way they're supposed to. So clot doesn't form the way they're supposed to. So people can bleed and bleed spontaneously. Let me give you an example. 25% thereabout of menstruating female who are having excessive menstrual blood loss suffer from von Willebrand disease, and no one ever even bother to test them for von Willebrand disease. And it is a frequent thing that when women are having menstrual cramps, they take a Motrin or an Advil, or they take aspirin. Well, and the bleeding get worse because Motrin is contraindicated, Advil is contraindicated when you have von Willebrand disease, and of course aspirin is contraindicated. You take one single aspirin, it will prevent your platelet from aggregating for 7 to 10 days. One single aspirin, not two, not three, one single aspirin. So you see the problem there. And nobody, as far as I know, it's not a routine thing for people to screen people with rheumatoid arthritis before they prescribe aspirin or before they prescribe the NSAID or a COX-2. It's not routinely done. Can you imagine that? Okay. Now I want you to imagine that there are more women in the world than there are men of the 7+ billion people. And you have a tremendous amount of younger women across the world that are menstruating. And they take aspirin, which is a fantastic medication. I took one aspirin this morning before I came to the studio. But you can't just take these things without getting medical advice. And most important of all, you have to explain to your practitioner, your physician who is helping you, what symptom you are having. Because if you have rheumatoid arthritis, which is, as I say, 1.2 million people, and last show I made an error by saying that juvenile arthritis was 700,000. That's wrong. It's 294,000 people in this country that is juvenile have rheumatoid arthritis. 1.3 million total, 294,000 of those are juvenile, not 700,000, which I said last week, which was an error. So this is very, very serious problem. Very serious problem. As I said before, clinical medicine is extremely complicated. So, and the medication that is used the most across the world to treat rheumatoid arthritis is aspirin, because that's what people have access to the most. And aspirin is a fantastic medication. But I just finished telling you, 1.10 million people across the world suffer from von Willebrand disease. And von Willebrand disease, aspirin is contraindicated. And it's not, it isn't just across the world. It is common practice for people to show up in an emergency room in the United States with some symptom, either they're having chest pain or they're having some kind of stroke type symptoms or God knows what else. They give them 2 aspirin. Well, I just finished telling you, 2.8 million people in this country have von Willebrand disease. So how many times people with von Willebrand disease will show up in an emergency room and they get the blood, they draw the blood, they hook them up to a bottle of normal saline, blah, 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 give them some oxygen if they need it, they give them 2 aspirin. Okay? Nobody bothered to think about one of these individuals may have von Willebrand disease. Okay? They just go ahead and do it. Okay? Now, to make matters worse, I don't mean to scare you, 400,000 people across the world have hemophilia. 80% of them is hemophilia A, 20% is hemophilia B. Now, get ready for this. Throughout life, 25% of people who develop hemophilia do so spontaneously during lifetime. They didn't inherit it anywhere. Okay? I don't mean to scare you, and these are the facts. So you just cannot do things like that without taking the time to do it completely and thoroughly. 25% of folks who develop hemophilia do so during lifetime spontaneously. How about that? Just think about that. Now think about the amount of time that folks themselves are taking aspirin because they have aches and pain or a fever or symptoms of viral infections or whatever, or they're taking Motrin, blah, 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 blah. And they don't know if they have hemophilia or not. And all of a sudden, they start bleeding, they wind up in an emergency room, and one thing leads to another, and catastrophe is going to happen. So you have to be careful how you do these things. So getting back then to how we treat rheumatoid arthritis with NSAID, well, we will prescribe the NSAID, be it Motrin, be it Mobic, be it naproxen, or what have you, for this individual, so that the inflammation can be blocked, which then relieves the pain. It has nothing to do with anything else. It will not go as far as dealing with the antigen-antibody complex that's causing the problem to develop in the first place. As I said last week, rheumatoid arthritis is an autoimmune disease. We don't know what causes it, but we know it's an autoimmune disease, meaning that the body reacts against itself and form this antigen complex. Then the body reacts against it and forms an antibody because the body reads it as foreign material. And then you suddenly have these antigen-antibody complexes all over the body, and it can affect any part of the body, from the brain all the way down to the foot and the ankle and the skin. Okay? That's what rheumatoid arthritis is. Okay? In addition to that, there's so many side effects that the rheumatoid arthritis itself can cause, from cardiac problem, from skin problem, brain problem, blood-related problem. You can't have rheumatoid arthritis and don't be anemic, okay? Because once you have an inflammatory disease, because rheumatoid arthritis is an autoimmune / inflammatory disease. Once you have an inflammatory disease of any types, I'm speaking this now specifically about rheumatoid arthritis, you are not going to be able to use iron. Either you eat the iron or take it by pill in order to produce red blood cells. The reason is because the inflammatory process itself blocks the ability of the transferrin receptor to grab onto the iron and take it into the bone marrow to be incorporated into early erythroblasts, early red blood cell, okay? Baby red blood cell, for you to make normal red blood, to eventually make adult red blood cell to prevent anemia. It ain't going to happen unless you force it to happen. and the block occurs right there, as I described it many, many times before dealing with different conditions. If you understand that, and then of course you wind up having to do what you know what to do to overcome the block, to allow the transferring protein to do its work by grabbing into the iron and the circulation and then take it into the bone marrow. You say, well, what happened to the iron? Well, the iron get deposited in different organs, including the joints. And wherever the iron is deposited, it must, by necessity, degrade. And as the iron is degrading, it's releasing free radical, causing an inflammatory process as well. So you have a double whammy. As a matter of fact, one medication that are being used frequently, and I use it frequently, is Procreate, which is man-made erythropoietin. Erythropoietin is a hormone that is made by the kidney to allow us to produce red blood cells. When we were a fetus in our mother's womb, it was made by the liver. Once we're growing up, becoming older, the kidney takes over, and the kidney produces it. However, now we're able to make it in the laboratory, creating medication called Procreate, which is, and also other types of different type medications similarly that are out there on the market. So it is common practice, once the joint, in this case, gets so damaged that the patient will go to the orthopedic doctor. At first, the patient is managed either by the general internist or by the rheumatologist. And then it reaches a point where the joint is so damaged because of the constant attack from these complexes that are depositing into the joint, inflammation, rupture of different tendon, whatever, and the joint has to be removed orthopedically. Well, here's the problem, and this is fascinating stuff. It is common practice, and that has been going on for the last maybe 25 years or so, or if not longer, that in preparation for the surgery to remove the joint, the patient is already anemic. It is common practice right now for the hematologist to get involved in the care of the patient via a referral to him or her, to then do the following. The patient is likely going to need blood transfusion. He or she requires her own blood to be given to her in the event that she needs blood during the surgery or after the surgery. So it is common practice right now, 90 days or so before the surgery is carried out, the patient will receive Procreate, also called Epogen, in order to improve the anemia to the point where the patient may, let's say the patient has a hematocrit 28%, 29%, 30%, blah, 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 blah. So we could give the patient Procreate to raise the hematocrit to the point where it is now around 35, 36%, because each unit of blood represents 3% of the hematocrit. So therefore then, we'll send the patient to the blood bank, now with a hematocrit of 36%, to give a unit of her or his own blood to the blood bank, to be kept so that he or she can receive that unit of blood in the event he or she needs blood as a result of the surgery. And the medication that is used to raise the hematocrit from 28% thereabout to about 35, 36% is Procreate or Epogen. How about that? Now, that was being done a long time ago. Now the same medication, Procreate or Epogen, is being used under all sorts of circumstances to raise someone's hematocrit. What happens is that you make the patient use his or her own iron. That's correct. You don't have to give iron. Sometimes we give iron intravenously while we're giving somebody Procreate, and there are different set of circumstances. But in this case, all you do The patient has a very high serum. You can't have rheumatoid arthritis without having a very high serum ferritin. That's right. So you have secondary hemochromatosis. That's correct, which is quite common in rheumatoid arthritis. So by giving the Procrit, you mobilize the iron that's sitting into the joint by overcoming the block that's preventing the transferrin protein from doing its work. So the patient uses his or her own iron to produce new red blood cell, therefore able to raise the, um, the hematocrit, and then the unit of blood can be taken out, and then you continue, of course, to give the Procrit, and then the patient then can go to get general anesthesia, which we would like for it to be, hematocrit to be around 30% or more to give general anesthesia. How about that? Okay, this is an amazing maneuver, clinical maneuver. So rheumatoid arthritis, therefore, is a systemic disease, inflammatory slash autoimmune disease that affects every joint in the body, and all other organs are affected to one degree or another, or can be affected. And I just finished talking about the red blood cell. Well, there's a condition called Felty's syndrome, and Felty's syndrome is frequently found in patients with rheumatoid arthritis, where they develop an enlarged spleen. Once you have an enlarged spleen, it is a given that your white blood cell is going to be low, your platelet is going to be low, and it is almost a given that your hematocrit is going to be low via a different mechanism. And the mechanism this time happens to be hemolysis. Because when you have splenomegaly, you likely, I know that I'm hitting you over the head with a bunch of incredible stuff, but somebody just told me this morning, don't make any excuses, Dr. Alcena, just because God give you a gift of intellectual blah, 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 blah. I'm not going to use the word that the person said because I don't want to feel like I'm being arrogant. But because you can't have splenomegaly for any length of time without having hemolysis. How about that? How do you go from rheumatoid arthritis to hemolysis? You do that via different mechanism. You do that via the Felty syndrome. So you're going to hemolyze. How about that? But that's not the only time you could hemolyze. Because believe it or not, rheumatoid arthritis, because it's an autoimmune disease, can also be associated sometime with autoimmune hemolytic anemia. That's correct. Anyone who has any types of autoimmune disease is at a risk of developing autoimmune hemolytic anemia. The same antigen antibody complexes that are causing the inflammation in the joint, etc., nothing can prevent them also from finding themselves on the surface of the red blood cell. How about that? And then you could develop an autoimmune hemolytic anemia whereby your red blood cells are hemolyzing, constantly hemolyzing, and there are ways of telling. Believe me, I'm not going to sit here and detail them for you, how one goes about diagnosing hemolytic anemia. This huge book that I just wrote, African American Men's Health, there's a chapter there on autoimmune hemolytic anemia, and it tells you all the different diseases that can be associated with it. And of course, rheumatoid arthritis can be one of them. So you see, you have to, that is one of the reasons why when someone has rheumatoid arthritis and you're evaluating the blood count, you must always do reticulocyte count. How about that? Because the reticulocyte count happens to be elevated when you're hemolyzing. There are other ways of telling, but again, you got to be very, very, very careful. I know that somebody's going to tell you that if you're hemolyzing, that if you do the indirect bilirubin, that's going to tell you yes or no. It may not. You know why? I shouldn't tell you, but I'll tell it to you anyway, because students and other academic folks listen to the show. Even if you are hemolyzing, if you have a good liver, how about that? If you have a good liver, and this is what I want you to write down, up to a bilirubin of 4. Remember that number. Up to a bilirubin of 4, the bilirubin may not be accumulating. How about the good liver is capable of getting rid of it. So if you're depending on the indirect bilirubin when you do the chemistry profile to tell you somebody is hemolyzing, you're out of luck, because it doesn't always happen because the person has a good liver and the liver can handle that. How about that? However, if you do an LDH and you do a reticulocyte count, now you're in business, because you cannot be hemolyzing and have a normal LDH. How about that? And you can be hemolyzing and have a normal reticulocyte count. So you see, this is academic medicine. And I said it, and I said it again, not to be arrogant, but academic medicine is completely different than community-based medicine. There's nothing wrong, absolutely nothing wrong with the community-based medicine. Those people are doing a fantastic job, they're excellent, but this is not the same as academia. In academia, we are expected, it is expected of us to be extremely detailed about everything, because we are teaching, like I just finished telling you here. When the students come to my office, I tell them to bring a notebook, a lab coat, and a stethoscope, and a pen. And I tell them this particular notebook will serve you 15, 20, 30 years from now as a reference to some of the stuff that I'm telling you right now that you may never heard before. Because you have to remember, when a textbook is written, I mean, this one took me 2 years, but the regular medical textbook take about 5 years to write, average. So by the time that book is out there, some of the stuff that's in the book is no longer valid. How about that? However, your teacher, the academic professor, is expected to be up to date to the last week. He or she is walking into the room where students are sitting there waiting to be taught. That's the difference. That is an expectation that must be met if you're going to dispense medical information to young men and women who are devoting themselves to do this, to learn this incredible, beautiful profession of medicine. There's no getting around it. You're either doing it, and guess what? Not every physicians that are practicing in academic institution are asked to teach. No, it doesn't happen like that. The chairman and chairwoman pick on those. I was about to go to California to practice medicine. I got my license. I went to a conference in San Diego. I fell in love with San Diego. Fell in love with it. And I was still in training for hematology. And as soon as I came back, I applied for a California license. So when the folks at Montefiore found out, that, because they had to find out because I filled out the papers, that I was getting a California license, I said, Val, you cannot do that. No way, Jose. We ain't going to let you go. I don't care. Okay? So because they wanted me to keep me so I can teach, because I was chief resident, and they know the ability that I had, the potential that I had. It was for no money. I was teaching just to be an attending physician at Montefiore, to teach pro bono, which is what I did. 25 years, 2 months a year for no money. But they wanted me there. And I did it for the commitment of it. For 2 years, for 25 years, 2 months a year, I would close my office, drove down to Montefiore to teach 7 days a week for 2 months. And I love every minute of it. And I'm telling you, I have been rewarded amply for it. Can't complain. Because I became a full professor. 17% of licensed physicians in this country get to be professor, and I became a professor, both at New York Hospital, at New York Medical College, and at Einstein, on the basis of my ability to teach the way medicine ought to be taught and to practice the way medicine is supposed to practice. That's all. No big deal. I don't have any aunt, uncle, brothers, or anybody pushing people to do X, Y, and Z for me. Everything I've achieved, I achieved with the help of God and with my own ability. How about that? So that's the way it is. So rheumatoid arthritis then is a very serious medical problem that must handle carefully, mostly by rheumatologists and by general internists and by orthopedic surgeons that have to do surgery to the joint, and the physical therapists that have to do the physical therapy, etc. And we prescribe the medications, the patient takes them, we do the MRI, we do the CAT scan, the x-rays, etc. And then we keep eyes on our patients so that other conditions that could be affected with this is not affecting them. And it is a very painful, crippling disease in most individuals. Serious business. So that is all basically I'm going to say about rheumatoid arthritis, because I've done, 4 shows on rheumatoid arthritis. You know it is treated with steroid. You know it is treated with the NSAID. You know it's treated with aspirin. You know it is treated with all the biologics that you see on television. You know it is treated with methotrexate, and so on and so forth. What more that need to be said? Nothing really. You know it is treated with physical therapy. You know you need sometime surgery to remove a joint, etc. And, this is it. That's rheumatoid arthritis. So next week, I'll find something else to talk about. Until such time, this is Dr. Alcena saying so long and bye-bye.